Good afternoon. Thank you for Dr. Cheng for introducing me before coming here. I am very honored that our picture is very popular in Singapore. So I would like to present my initial clinical experience in Petrov Research Institute of Oncology, St. Petersburg. Интересно. Туда? Okay. Prostate cancer is an age-related disease. Overall, 1 of 6 men in Western world is expected to be diagnosed with prostate cancer throughout his life. PSA screening programs and lowered threshold for biopsy performance resulted in down-migrated of the age of prostate cancer detection, the stage of disease at detection. 45 to 85% of patients have low-risk prostate cancer. Local treatment of localized low-risk prostate cancer. Currently, investigation management modality offers patients with low-risk prostate cancer a middle-ground therapeutic option, aim to avoid the quality of life impairments associated with radical treatments with active surveillance. Compliance with international task for requirements for focal treatment of prostate cancer. Requirements and MRI-guided FUS compliance. Effectiveness ablation of entire tugboat zone. X-ablate enable whole gland and all focal treatments. Safety, minimal injury to essential functional structure. Non-invasive treatment, accurate guidance, sharp spot boundaries, use of ladders. Real-time monitoring, real-time MR thermometry, accumulated dose display. Percutaneous access, we have a rectal transducer. Reliable imaging for patient selection, treatment targeting, immediate result evaluation, follow-up. High-resolution MRI imaging, retreatment without excess morbidity, protection of the rectal wall does not reduce safety potential retreatments. Be affordable. Single session treatment costs less than prostatectomy or radiation. The X-ablate 2100 prostate system. You can see endorectal probe, motion unit, positioning. 990 elements phased array transducer, good control of sonication spot size, mechanical and electrical steering for coverage of entire prostate. Single-use endorectal balloon, circulation in degassed cold water provides rectal protection. MRI focus ultrasound for prostate cancer in Petrov treatment setup. 1-point TG MRI suite plus torso PA coil. Position supine head first. Treatment is conducted via an endorectal FUS transducer. In Petrov, all patients had epidural anesthesia plus conscious sedation. An attending anesthesiologist during treatment. Continuous heart rate, saturation, and blood pressure monitoring. Urinary blood drainage. In Petrov, all patients had a Foley catheter since treatment did not involve the urethra. MRI-focused ultrasound focal prostate cancer treatment requires multidisciplinary patient management, adequate patient selection, precise treatment, continuous follow-up. All of stage require multidisciplinary team cooperation, urologist, MRI radiologist, and anesthetist. You can see real-time MR thermometry and accumulated dose. Display provide closed-loop feedback, allowing the use of further dose adjustment and case-dependent treatment customization. And immediate post-treatment non-perfused volume indicates preliminary technical treatment effect on the image tissue. Up to date for patient age 54, 72 years with biopsy-proven prostate cancer were treated in our institute. All treatments were performed under research protocols approved by local ethics committee. All treatments comprise a true-focal ablation of areas identified by biopsy as harboring cancerous focus. Feasibility study aims technical and safety evaluation of the X-ablate system for focal treatment of the patient with low-risk prostate cancer. Assessing operation and technical requirements for effectiveness achievement. Obtain investigation feedbacks to be improved system usability, treatment flow simplification, define phase 2 study protocol requirements, patient selection, treatment extent customization, and outcome measures. Pre-treatment evaluation and cancer localization. Patient underwent as part of pre-treatment evaluation CT multifunctional MRI plus spectroscopy, prostate biopsy. Only 2 patients had MRI visible tumors. 1 spectroscopy, 1 T2 weighting imaging. Treatments were based on biopsy results. 2 patients had standard 12-core transrectal guided biopsy, and 2 had 16-core transperineal transguided biopsy. Regional treatments were marked to include the areas from where positive biopsy were reported to be obtained with generous margins. In our 4 first treatments, mean duration about 5 hours. Main time consuming factor and corrective actions. Initial position of the transducer. Based on screen MRI estimate initial position and try to adjust position in a single step. Drawn the prostate and ladders. Gaining experience, GUI friendly improvement. Removal of eye drape in the balloon rectum interface. Changing in a larger interrectal balloon, replace the large amount of the viscous ultrasound gel. Patients' movements that require repositioning. Important to insist the adequate anesthesia with deep muscle relaxation, where the patient unable to move. Technical effectiveness. The cumulative dose correlate with immediate post-treatment non-perfused volume. Preliminary safety results. No adverse event occurred during procedure on follow-up periods. In all our 4 patients, catheter were removed less 24 hours post-treatment. 3 patients felt minimal discomfort with slight worsening of excited urinary obstructive symptoms during the first 2 to 7 post-treatment days. They were spontaneously resolved. 1 patient had no symptoms at all. At 1 week follow-up, 2 patients with baseline incontinence symptoms reported minimal worsening of symptoms. Both reduced for baseline long before their 1 month visit. By 1 month follow-up visit, urinary flow and sexual function returned to baseline level in all our patients. Primary study efficacy outcome measure in the 6 months pathology obtained from repeat biopsy. 3 patients did not reach this point yet. First patient biopsy result returned negative. Nevertheless, PSA follow-up levels reveal limited success. This may be related to false negative biopsy or false tumor localization, since post-treatment NPVs covered the target areas. Also, the start, not always easy. Conclusions. We strongly believe that X-ablate MR-guided focus ultrasound can provide safe and effective therapeutic options for patients with low-risk prostate cancer. Focal treatments is the preferable options for selected group patients. However, adequate patient selections and accurate mapping biopsy is mandatory to focal treatments since low-grade cancer tumors are usually not visible under MRI. I'm very grateful to NCTech for the opportunity to work with Exaplate. Many thanks to David Friendlich, Doris Schecher, Shlomi Rudich, and others NCTech personnel for their help and constant support. Thank you for your attention.
Thank you very much. This paper is now open to questions, please, from the audience. One question in the back. Sorry, it's you.
Oh, sorry. So addressing the statement you said, without good localization of prostate cancer, we're blind, do you believe a 12-core or 16-core biopsy is adequate for focal therapy? The previous paper had 30 to 50 core.
No, it's not enough, because we being first, it is the first experience, and maybe in future it's more better robotic system in doctor